Congratulations on being here. And again, we should thank Manos et al. For all their work and all the people that also have done all the administrative work. It's been very smooth and efficient and very nice. So anyway, so I get the nice last topic to talk a little bit about instability, which has been covered a little bit so far today. So these are my disclosures. I've not lost any weight since the last talk. So the extent of the problem is instability still continues to be probably the most common complication for reverse total shoulder arthroplasty. Systematic review back in 2011, instability was 4.7%. It's actually gotten better as people learned how to do this operation and are doing it better. In 2022, though, it was down to only 2.5%. So I think even though it's fairly low, it's still somewhat problematic. By diagnosis, rheumatoid arthritis is one of the major complications or reasons for having instability. Also, revision arthroplasty is 1.8%, and proximal humerus fracture is 1.7%. Failed arthroplasty, you would expect it's 5.8%. Proximal humerus fractures is 4.1%, which I find interesting because most of the time proximal humerus fractures they scar in so much that they don't get enough motion to dislocate. And oddly enough, and this was discussed the other day, instability arthropathy, which you would think people would have a tendency to be unstable, they actually do fairly well. The only reason to really talk about it very much, though, is that it can drive you crazy. And sort of to prove that, if you look at how many patients that have instability, how many operations they need to try to solve their instability, there's quite a few. So of those who, in this review by Nandari in the group, they had 50 patients and 80% required surgery, but 17% had recurrent instability, and 14 of those 35% of the patients actually required another surgery. The Frankel group, they had 32 patients had, 32 patients with 36 shoulders required 38 revisions, and the average number of revisions for the failed primaries was 3. And for patients who had revisions, they had on average another 4.5 operations. So getting this problem solved, even though it's not as common as it used to be, can be quite challenging and sometimes frustrating. So the main treatment for instability, however, is prevention. And Frankel divided the groups into, or the causes into lack of compression, a lack of containment, and also impingement. But really, I think some of the major factors are design in the prosthesis. It's really clear that a 135 and 145 have much less instability than a 155 head neck angle on the prosthesis on the tray. The soft tissue envelope, we all know, is oftentimes fibrotic or very extensile. Loss of proximal humeral bone is a really critical portion of this. And also, people have retained greater tuberosity fractures where the greater tuberosity fragment is in the posterior part of the shoulder. So when you go to rotate, particularly externally rotate, it kicks the proximal humerus out the front. And then it's been alluded to, revision surgeries also are very apt to instability. So this is an interesting study because it's, I think, coming out. If it hasn't come out already, it's going to be in the next few months. But there is American Shoulder and Elbow Society actually has complications of RSA multi-center research group. And I think, George, you might be in that group. I'm not sure. I think there's 40 or 50 physicians or surgeons. And so they looked up the predictors of dislocation by odds ratio, and the p-value is like 0.001, which is for an odds ratio, it's pretty astonishing. But the largest, I don't know if we can get that video to play, but the largest predictor of dislocation or true dislocations versus just instability or someone who has a subluxation like this, so you can imagine that they would go on to have chronic instability. Males are 2 times larger or 2 times more frequent to have instability revisions. We talked about 5.6. not repairing the subscapularis has been talked about at this meeting. Acute fractures or fracture non-unions are really fairly common cause for recurrent instability. Interestingly, if you can, again, if somebody can show you the subluxation, they probably really are dislocating as well. Cuff tear arthropathy patients tend to also have instability, and primarily because they just don't have as much soft tissue to hold the shoulder in. Patient factors that are important are proximal humeral bone loss, which was mentioned in a couple of the earlier talks. Missing the greater tuberosity is a serious problem and probably needs to be resolved, as George mentioned earlier. Fracture non-unions or malunions, the greater tuberosity fragment I just mentioned. Cuff tear arthropathy is a risk. Axillary nerve palsy is a risk. Cuff tear arthropathy is in there twice for some stupid reason. And then axillary nerve palsies, again, can make you unstable. So the things to do, though, is things that we know that increase stability are the bigger the glenosphere size, the bigger is better. If you have an eccentric glenosphere design, then having the eccentricity inferior is better. As far as glenosphere lateralization, that can also put tension on the system, but sometimes it increases the deltoid stress. Inlay versus onlay. Onlay is better in terms of providing stability because inlay sometimes essentially shortens the humerus. Glenosphere tilt, if you have tilt superiorly, again at 10 to 15 degrees, that's sort of the threshold at which instability begins to occur. Also, the polyethylene depth can sometimes decrease the motion, and then the head-neck angle I just mentioned a minute ago. These are some, this is sort of how I figured out that the head-neck angle made a difference. When I first started doing these, I was using a Grammont-type prosthesis, and the instability rate of not so many patients, but one of the reasons I stopped doing it was because the instability rate was 17%, and the notching rate was 72%. So then I went to a 135 head-neck angle, or tray shaft angle, and had no instability, and the notching went down to 23%. So I think that probably still is the case. I think most people these days would try to avoid a 155-degree head-neck angle. The other thing is that the first line of treatment for most of these patients is a closed reduction, and sometimes you can get lucky with that. I think the further out from when the index operation was, the less of a success. But at 28 months after a closed reduction, approximately 60% were still stable, which is a pretty good number. But again, that's 40% who are going to continue to be unstable and probably need an operation. Olson et al. Did a survey or summary of the literature, and they found from 3 studies that really talked about it that non-operative treatment, the recurrence rate was from, or I'm sorry, the success rate was from 28% to 100%, probably not 100%, but also another study in 2015 found that there was only a 25% rate in stability from a closed reduction, and the rest needed surgery. So really the main thing, though, for shoulders and preventing instability is to increase the compression on the greater tuberosity. So that involves having an intact deltoid, but also having an intact greater tuberosity proximally. So for the muscles and the soft tissue to provide really good compressive force to keep the shoulder in the socket, you need to have a greater tuberosity and you need to have an intact deltoid. So prevention is the best policy. Number one, when you do fractures or any operation around the proximal humerus, don't throw out the tuberosities because you need the compression by the deltoid. And the larger the defect in the bone, as several of the speakers have said today, is really a bad problem. Number two, don't leave the greater tuberosity fragment posteriorly behind because I mentioned when you go to externally rotate, it kicks it out the front. It's very difficult to see the greater tuberosity fragments here, but they are fairly visible, which is oftentimes part of the problem. If you use an inlay humeral prosthesis, consider repairing the subscapularis back. That's a sort of somewhat of a theoretical problem as long as everything is balanced. If someone has a cuff tear arthropathy, I tend to put the implant in a little bit tighter than I would normally. That's either with thicker polyethylene as seen on the left, or putting in a thicker tray as you can see on the right. And I tend to use the tightness on the conjoint tendon as a guide as to how tight or how loose it is. The last, of course, has been mentioned, is using a constrained or retentive polyethylene insert. So in terms of evaluation of recurrent dislocator, I think the first thing to do is to figure out what the extent of the rotator cuff deficiency is. A lot of times you can't do much about that. You also want to do a neurologic evaluation, make sure the axillary nerve is intact. You want to then determine how much proximal bone loss there is, and if the tuberosities are missing, you can use the radiographic length of the prosthesis, or I'm sorry, the deficit that George mentioned earlier. So you want to determine how much bone is missing. Again, you also, as mentioned before, you want to rule out infection. And then also you need to figure out what the prosthesis configuration is, and particularly in terms of its metaphyseal head-neck angle junction. I recently had a patient, oddly enough, somebody put in a 155. I couldn't believe it. So all we did was just change it to a 135, and he was stable and has stayed stable for a year. So the first steps, I think, is number one, increase the glenoid diameter and thickness, particularly if it's a more lateralized component. And also consider putting in an eccentric glenosphere. You can increase the tray and polyethylene thickness, which is a good first step, but a lot of times that doesn't get it done, so you maybe should consider retentive polyethylene at the first go-around. Also, you have to make sure that you remove any capsular contributions to the instability, particularly contracture in the back, as I mentioned before. Then the last steps, this has been alluded to before, probably one of the best solutions for chronic instability is an APC, as George talked about. You can also do a tumor prosthesis. I tend not to like tumor prostheses too much because they're kind of big and bulky, and I think particularly there's a lot of juncture problems and the stems tend to get loose, and then you've got a big problem because you've got to deal with the cement. So the last steps, if you're really desperate, Tajin back in 2018 reported on 3 cases where he used a cerclage wire or tapes rather like this to sort of hold things together. He only reported 3 cases. I've not seen any since. I don't know if any of the speakers here have any experience with this, but I've not tried it. So again, the options, if you can't get the person to stay located, is you can just leave it dislocated. Oddly enough, it looks terrible, but sometimes it's the only choice. You can try hemiarthroplasty with a large head. Issue with that, of course, is patients still get glenoid erosion medially. You can try to do a fusion, which is difficult because of bone quality or lack of bone. And then the last, of course, would be a resection arthroplasty like this. And oddly enough, some people can get by depending on their history. So in summary, fortunately, instability has become less of a problem in our field. Prevention, of course, is the best policy. You should always try you should always start with a closed reduction first, and hopefully non-operative treatment will make it better. If it doesn't, then you need to determine the problem and address it in a organized way. And fortunately, I think most people have had revision work. Most of them get better, and treatment is successful. So it's been a great meeting. Hopefully you won't have too many instabilities to worry about, or infections, and or nerve damage, and we all can enjoy our arthroplasties with our patients. Thank you.